Okay, so welcome everyone to the lecture of Dr. Hyder Step 1 for cardiovascular system. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Okay. Thank you so much for joining the lecture. Hope you guys are doing well. Thank you so much for waiting for the rest of the students to join and for the lectures to begin. We appreciate your patience. Before we begin the lecture for today, and we sort of wait for a couple of more students to come and join, can we do a quick revision and recapitulation of the topics from yesterday? Yes or no? Yes. Is everyone ready for a revision and recapitulation? Can everyone hear my voice? Is everyone ready? Yes or no? Okay. Uh, so let's begin with a little bit of revision and recapitulation. Let's start the lecture for today. First and foremost, over here, um, let's start talking about some equations with which we started our lecture yesterday. That's what I remember, right? Can anyone tell me over here very quickly, what is the equation for stroke volume? Stroke volume. Stroke volume equals to? Anyone? Thank you so much. And diastolic volume minus and systolic volume. Very good. What is the equation for ejection fraction? What is the equation for ejection fraction? Okay. Pulse pressure is increased. My apologies. Pulse pressure is decreased in a couple of conditions. What are the names of those conditions? Aortic stenosis, then cardiogenic shock. Very good. Then what else? Okay, very good. If you have a patient who comes to you with an atherosclerotic narrowing of the blood vessels, and the radius of the blood vessels is decreased by a factor of 2. The resistance of the blood vessels are increased by what factor? Okay, good. Um, if you have this sort of a presentation, okay, 1 second, please. If you have this sort of a presentation, right? This is your normal cardiac output versus right atrial pressure. Okay. Instead of this, if I do this, what is the reason for the new dotted line? Inotropy, very good. If instead of this, I did this, what is the reason for the new dotted line? Decreased inotropy. Very good. Not loss of blood, decreased inotropy. If in cardiac output versus right atrial pressure, if I draw something like this, then what is the reason for the new dotted line? Fast answers, please. Increase of fluid. How about something like this? blood loss. Okay. Okay, very good. Thank you so much. How about the midpoint comes up to here? What is the reason? Fast answers, please. Increased total peripheral resistance or decreased total peripheral resistance. If it comes from here to here, this is decreased, not increased. Yes? Okay, it makes sense, right? Look, let's think about it very simply. Think about it as simply as possible. Do not mix this up. Cardiac output, venous return. Does this indicate high cardiac output and a high venous return? This sort of a curve? Yes. Look, if I have to put values 1, 2, 3, 4, then look, the rate of increase of cardiac output is increasing very easily. The rate of venous return back to the heart is increasing very easily. When does blood flow increase through the blood vessels easily? When the resistance is high or when the resistance is low? Fast answers, please. When the resistance is low. Okay, so are we going to make the same mistake again? Yes or no? No. Okay, do not make the same mistake again, please. Whenever you see something like this, and it comes from here to here, the dot, this indicates decreased total peripheral resistance, as simple as that. Okay, please not make the same mistake again. Next one is very quickly, a couple of questions, then I'll move forward. If I draw something like this, pressure volume loop, if this is the normal, if I draw something like this, the new one, what does this indicate? This new one, what does this one indicate? This indicate increase of afterload, preload, or contractility? Which one? Afterload, very good. If I draw something like this, does this indicate increased preload, afterload, or contractility? Fast answers, please. Preload. If I draw something like, this is the normal, and I draw another one like this. What does this one indicate? Increase of contractility. What is the valvular abnormality for this one? This is the normal, and this is the new one. What is the valvular abnormality for this one? Aortic regurgitation. Okay, or if I tell you that this is not aortic regurgitation, how? Okay, look, let me give you a very good example. Okay, let me draw it one more time, then you will know why your answer is incorrect. Okay, no problem. This is the normal, right? And this is the one I talked about. If it was aortic regurgitation, more blood will come back to the heart by regurgitation of the aortic valves. Yes or no? Fast answers, please. If the answer is more blood will come back to the heart because it will regurgitate back. As a result, end diastolic volume is going to be high. Yes or no? The answer is yes. And the contractility will be high because of increased preload, meaning that force of contraction is going to be high. So as a result, what would happen to the stroke volume in aortic regurgitation? Will it be high or will it be low? Stroke volume in aortic regurgitation as a result, is it going to be high or low? High. So over here in the red one, Do you think the stroke volume is higher than the purple one? Yes or no? No. So can this be aortic regurgitation or mitral regurgitation in any way whatsoever? No. So what is this one? This is mitral stenosis. Why is this not mitral regurgitation? In mitral regurgitation, when the left ventricle contracts, blood flows back to the left atrium. As a result, during the rapid filling phase, the atria contracts, more blood comes back to the left ventricle, once again increasing the amount of blood in the left ventricle and increasing the contraction of the left ventricle, the stretching of the left ventricle, and increasing the contractions of the left ventricle, resulting in increased stroke volume or decreased stroke volume in mitral regurgitation. Mitral regurgitation, increased stroke volume or decreased stroke volume? Okay. Decreased stroke volume. Okay, so if the stroke volume over here in mitral regurgitation, if the stroke volume decreases, right? If the stroke volume decreases, and in mitral regurgitation over here, are you sure that the stroke volume will decrease or the stroke volume will increase? Can you please think about this one more time? Okay, let me explain this one more time. In mitral regurgitation, why will the stroke volume increase? When the left ventricle contracts, will blood go back to the left atrium? Yes or no? As a result, when blood comes back over here, when blood comes back to the left ventricle will contract. Will the left ventricle contract more or contract less? The left ventricle will contract more. If the left ventricle contract more, will more blood get out or more blood stay back? Fast answers, please. Exactly. So shouldn't the stroke volume be higher in mitral regurgitation? Yes or no? Yes. Okay. I still suspect a little bit of hesitancy and confusion. Yes, we're still a little bit confused. Yes or no? Yes, we're still confused. Okay. There is absolutely zero room for confusion. We cannot be confused, especially in step 1 exam. Okay, I'm going to do this one more time. This is your assumption of a normal pressure volume loop. Are we clear up to now? This is the heart, this is the pressure volume loop. This is the normal heart, this is the normal pressure volume loop. Okay, are we ready? Let's talk about the first condition. The first condition is that we have an aortic stenosis. If we have an aortic stenosis, what would happen to the stroke volume? Will it be high or will it be low? Fast answers, please. Low. What would happen to the amount of blood that stays back in the heart after the ventricle contracts, meaning end systolic volume? Will it be high or will it be low? Thank you. It will be high. End diastolic volume, will it change or not? End diastolic volume, it will not change because there's no problem with relaxation. So the graph will look something like this. Yes. Clear? Clear or not? Yes, okay. In aortic stenosis, this shows what? That end diastolic volume is the same, end systolic volume over here is increased, stroke volume over here is decreased, and the amount of force that the heart needs to contract with is increased. Yes or no? So the pressure is increased. So it would look something like this. Clear? Okay. Okay. Next one. Next one. Okay. Next one is there is a mitral regurgitation. There is a mitral regurgitation. So when the left ventricle contracts, right? This is the aorta. When the left ventricle contracts, instead of the blood, all the blood going through this way, will more blood flow back into the left atrium? Fast answers, please. Yes or no? Yes. As a result, when the atria contracts, will more blood come back to the left ventricle? Yes or no? The answer is yes. As a result, again, when the left ventricle will contract, now will more blood flow out? Yes or no? Fast answers, please. So are you saying that the stroke volume will increase or decrease? Stroke volume will increase. Okay, what about end diastolic volume? Will it be high or will it be low? Because over here, diastolic volume is going to be high. Why? Because during ventricular relaxation, more blood will flow back to the left ventricle because more blood is available in the left atrium. So end diastolic volume will come from here to here. End systolic volume, will it remain normal? Yes or no? The answer is yes, or it might decrease a little bit. So either it could be here or it could be here. It's not that necessary until and unless you're trying to compare. So will the graph look like this? Yes or no? Okay. So we're clear. Next one is if there is, okay, if there is aortic regurgitation, okay, if there is an aortic regurgitation. So for example, this is the aorta. Over here, you have a regurgitant valve. So more blood when the left ventricle contracts, will more blood come back to the left ventricle? Yes or no? Initially, the answer is yes. If more blood comes back to the left ventricle during end diastolic volume, will we have more blood or less blood? Fast answers, please. We will have more blood. Very good. So according to Frank Sterling's law, if there's more blood in the left ventricle, the stretching will be more. As a result, contractions will be more. So once again, when the left ventricle contracts, will more blood leave the heart? Yes or no? The answer is yes. Stroke volume should be high or low? Stroke volume will be high. End diastolic volume is going to be high. End systolic volume is either going to be normal or slightly increased. Okay, because more blood is flowing back. So the new curve, okay, so the new curve will look something like this, very similar to mitral regurgitation. The only difference is in mitral regurgitation, end systolic volume is normal or decreased. In aortic regurgitation, end systolic volume is normal or increased. Are we clear? Yes or no? Okay. Next one is if this is the pressure volume curve and I draw a new curve that looks something like this. This shows stroke volume has decreased, end diastolic volume has decreased, and systolic volume is normal. What is your valvular abnormality for this one? Mitral stenosis. Okay, why is end diastolic volume decreased in mitral stenosis? If there's a stenotic valve during diastole, less blood will flow from the atrium to the ventricles. As a result, end diastolic volume will decrease. And since there's less availability of the blood in the left ventricle, according to Frank Sterling's law, the stretching will be less. So the contractions will be less. As a result, stroke volume is going to be less. So stroke volume is less. Will there be a change in end systolic volume? The answer is no. End systolic volume will remain the same. Okay. Are we absolutely clear? Yes or no? Okay. There shall be no room for confusion. Please do not be confused. Look, let me tell you something very, very clearly. Okay, then let me be very, very clear. First and foremost, you guys are studying USMLE step 1. That's hard itself. Secondly, you're not studying by yourself. You are studying with a tutor. Yes. So are you studying for free? Yes or no? Are you studying with a tutor for free? The answer is no, right? So basically, you are paying us for your service. What does that mean? That means if you do not understand anything, it's our duty to repeat the information 10 times, 20 times to make sure that you understand the thing. So the reason why I'm saying this is please do not hesitate or do not be afraid to ask questions and ask us to repeat ourselves. Are we clear? Yes or no? Because a lot of us, right? A lot of us, we might be doing classes um, in a setting of an international medical I mean, we have done our graduation from international medical schools, and like we know how difficult it is to approach tutors and teachers in international medical schools, right? But not over here. Over here, if you are confused, it's your right to clear your confusion. You have to ask us as many times possible. If I do not have the time to explain the concepts during the lecture, ask me after the lectures are over. I'll explain it then. Okay, but please do not stay confused. Okay, are we clear? Yes or no? So in the future, if we do not understand anything, if we're confused, are we going to repeat ourselves? Are we going to ask more questions? Yes or no? The answer is yes. Okay, please think of me as your friend. Please ask me questions. I insist, ask me questions. Okay, please make sure that you clear your concepts. Okay, there's another thing that you can do during the lecture is if you do not understand anything, please keep a page where you write down with the stars. For example, let's say today we're going to talk about heart sounds, right? And you do not understand anything, write down, for example, systolic murmur. I did not understand this, right? If you don't want to bother the class or if that's what you think, after the class is over, please make sure that you ask me your confusions. Okay, are we clear? Okay, good. Let's begin. So yesterday we have also finished splitting of S2. Very quickly before I begin the lecture from over here, what is the cause of physiological splitting? What is the cause of physiological splitting? Inspiration. What is the cause of wide splitting? What is the cause of wide splitting? Very good. What is the cause of fixed splitting of S2? Okay. What is the cause of paradoxical splitting? Okay. Okay. Now let's come to the text over here, auscultation of the heart. Let's begin from over here. Now, in your USMLE step 1, during your examination, you will have some questions where this will be a simulation like questions, right? For example, what is the simulation? The simulation is you will basically use your mouse or your cursor to put the stethoscope in the computer, and you have to put it in different regions, in the mitral area, tricuspid area, pulmonary area, and aortic area. You have to put it in these regions to hear the variance of heart sound. So for this, do you have to know the locations of the areas, mitral, tricuspid, pulmonic, and the aortic? The answer is yes and no. Yes, meaning that you should know this for the fact that when you practice medicine, and for example, the attending physician asks you to auscultate the mitral area, instead of doing it at the left fifth intercostal space, you're just doing it randomly over here or here, right? That would be very embarrassing. So you should know this 100%, but for the exam, the areas are going to be designated. All you have to do is take the stethoscope with your mouse and place it in the respected area each time to hear the different sounds. Okay, so that's that. So having said this, let's begin. Over here, auscultations of the heart, where do we listen? Now, please write this down in your book. The mitral area is at the left fifth intercostal space in the mid-clavicular line, right? In the mid-clavicular line. This is the clavicle. In the mid-clavicular line, we hear at the left fifth intercostal space, we can hear the mitral sound. Where do we hear the pulmonic sound, the pulmonic area? The pulmonic area is basically at the left second intercostal space along the sternal border. So sometimes in your questions, they will tell you that the auscultation was done at the left second intercostal space along the sternal border. So when they describe that area, you have to right away remember that that area is the area of the pulmonic area. So this one, please write down left second intercostal space. This is obviously the aortic area that's at the right second intercostal space along the sternal border. And this is the tricuspid area. Tricuspid area is at the left third intercostal space along the sternal border. Okay, are we clear? Yes or no? Okay. So let's talk about something over here very quickly. I want to make sure that your concept is as clear as possible. Okay, so this is is this the heart? Or is this a heart or is this a walnut? This is a heart, right? So what's happening over here? Okay, and here we go. Okay, so this is the heart, right? Over here, this is the right side, this is the left side, this is the pulmonary blood vessel, this is the aortic blood vessel. Okay, this is these are the valves. What type of a valve is this? This valve over here, this is a tricuspid valve, yes or no? On the right side, this is a tricuspid valve. This is the pulmonic valve. This is the mitral valve, and this is the aortic valve. Aortic valve. Okay. So now let's talk about this over here. Let's talk about the first one, mitral and tricuspid valve. So the changes in this portion with the sound and everything is going to be the same. So what's going on over here? Why am I talking about it? I'm talking about this over here because there are basically two functions of the heart, right? The two functions of the heart is contraction and relaxation. So when we say this, we say systole and diastole. So during systole, if you hear a sound, we call this systolic murmur, systolic murmur. And during diastole, if you hear a sound, we call this diastolic murmur. Okay. Now, what is and why do we hear murmur? It's very easy to understand. If this is a blood vessel or a compartment, blood should always flow in a laminar direction like this. This is the optimum way that blood should flow. If blood flows like this, we hear no sound. Okay, but in a compartment or in a blood vessel, if the blood does not flow like this, if the blood starts flowing like this, we call this type of blood flow as a turbulent blood flow. And in turbulent blood flow, we hear murmur. Are we clear? Yes or no? So let's talk about systole first. Okay. During the systolic phase, the left ventricle will contract. Yes. So we are talking about, for example, we're talking about, let's say in the mitral area, at the left fifth intercostal space in the mid-clavicular line, you do an auscultation, right? And do you remember yesterday when I said that when we auscultate the patients, we try to put our fingers, especially the thumb, on the carotids, yes or no? All right. If the pulse corresponds with the carotid, then it's a systolic pulse. If the pulse does corresponds, or if it does not correspond, then it's a diastolic pulse. So having said that, in the mitral area, when the left ventricle contracts, right? So when the left ventricle, when they contract like this, blood will move out through this way. Yes or no? So when the left ventricle contracts, we want the blood to move through this way. As a result, should the mitral valve